The CheckMate 9LA was a randomized phase 3 trial, and the principal question that we investigated in that trial was a combination of chemotherapy plus an immunotherapy combination, Nivolumab and Ipilimumab, compared to chemotherapy alone as a first-line treatment opportunity. And the idea behind the CheckMate 9LA was the fast control of the tumor by using a limited course of chemotherapy, 2 cycles, and the long-term survival control by the immunotherapy combination of Nivolumab and Ipilimumab compared to chemotherapy alone. This was the concept, and we have seen across tumor entities that this combination of Nivolumab and Ipilimumab is able to provide long-term overall survival control. We also have seen this in lung cancer in the CheckMate 227 trial, and now we wanted to add something to have a fast tumor control, and this was chemotherapy. Well, the patients were randomized either to standard treatment, which was chemotherapy, 4 cycles of histology-based chemotherapy with the opportunity of maintenance if they had a histology of non-squamous, non-small cell lung cancer, or they were randomized to the experimental arm, which was a combination of 2 cycles of chemotherapy, Nivolumab with a fixed dose of 360 milligram, and Ipilimumab with a very low dose, 1 milligram per kilogram body weight every 6 weeks. And the principal endpoint, primary endpoint, was overall survival. Secondary endpoints were progression-free survival, response, and the efficacy related to the PD-L1 expression. And the stratification factors were gender, histology, and the PD-L1 expression on the tumor cells. Well, what we are presenting here at ASCO is the outcome number 1 of the interim analysis. So there was a pre-specified interim analysis looking on the primary endpoint of overall survival, and the data monitoring committee confirmed the superiority of overall survival for the combination compared to chemotherapy alone after this interim analysis. And then we tested hierarchically progression-free survival and response, and they also were in favor of the combination arm. This is the first part. So we have seen a significant improvement in overall survival for the combination of 2 cycles of chemotherapy together with Nivolumab and Ipilimumab. The second part was a second analysis after 4 months of follow-up. And what we do see there is a very solid confirmation of the data. There's a solid improvement of overall survival. There's even a better overall survival associated with the combination of chemotherapy, Nivolumab and Ipilimumab. We are talking about, just give me a minute, we are talking about a hazard ratio of 0.6. By 0.66, we are talking about a median overall survival of 15.6 months compared to 10.6 for chemotherapy. And what we do see when we look on the Kaplan-Meier curves, there's an early and consistent separation of these curves. There's no crossing of the curves. And currently, we have a 1-year overall survival benefit of 63% compared to 47% in the control arm. And still, we have a lot of patients who are under observation, who are censored. So we are going to expect to become this data better over time with further follow-ups. So this is a clearly positive trial. And what we also have seen when we look on response was significantly improved in favor of the combination arm. The rate of primary progressions following the combination therapy was lower compared to the primary progression rate following just chemotherapy alone. This tells us something about the very fast tumor control, which was better under the combination of chemotherapy and Nivolumab and Ipilimumab. Well, something also to talk about tolerability. This is always an important question. We are talking about an intensive combination because we really want to treat the tumor fast and we want to maintain the efficacy of our treatment. What we have seen is that indeed there was a higher rate of treatment-related adverse events. There was also a higher rate of treatment-related adverse events leading to treatment discontinuation of any of the components. However, we also have to see that the treatment duration of the combination arm was much longer compared to the control arm. And the rate of fatal toxicities was very, very low in both arms, 2% in both of the arms. Some interesting findings with regard of tolerability. Number one, when we look on typical chemotherapy-associated adverse events, the incidence rate in the combination arm with only 2 cycles of chemotherapy of certain chemotherapy-associated adverse events was lower. So when we look on the schedule of chemotherapy-associated adverse events, the frequency of anemia, neutropenia, and thrombocytopenia was lower compared to the conventional chemotherapy arm. And the other question was, what about the immune-related adverse events? And we do see a very similar picture of immune-related adverse events compared to the CheckMate 2-7. There was no increase of immune-related adverse events by the addition of chemotherapy. The majority of this immune-related adverse events was mild to moderate, and the most frequent immune-related adverse event was skin toxicity, followed by asthenia and GI toxicities. So in summary, what we have seen in the CheckMate 9LA, number one, it's a positive trial. We have seen a significant improvement in overall survival, progression-free survival, and response. We have seen a confirmation of the outcomes with 4 months of further follow-up, and we haven't seen any new safety signals by the use of this combination. So this is a very interesting new combination, which we might offer our patients as a first-line treatment opportunity for metastatic non-small cell lung cancer.